Good morning, good afternoon, everyone. Welcome to today's webinar on the limitations of Medicaid data. My name is Azucena Monroy from Acumen LLC. I'm a Senior Policy Associate and the Data Lead for the Linkage program. I have some colleagues with me today. Also, Iri Massam from NIA joined us. From Acumen, there's Derek Fenson. He's a Research Manager and a Medicaid Data Lead. He will participate in the Q&A session at the end of the presentation. Christina Bird is the lead information coordinator for the Linkage program, and she will be assisting us with the poll and the Q&A as well. Kira Martin will also be supporting us in the Q&A session. I'd like to invite you to attend our next webinar titled Using National Long-Term Care Survey CMS linked data on July 24 at 9 a.m. Pacific time, noon Eastern time, presented by NLTCS, one of the studies that are part of the NIA data linkage program. The agenda for today is to provide you with an overview of the Medicaid data and the transition to TMSs, to highlight differences between MACs and TMSs, to mention useful information found in the Medicaid data, as well as some challenges working with the Medicaid data. We'll end with questions and answers. Let's start with an overview of the Medicaid program. As of February 2024, there were 83.4 million individuals enrolled in Medicaid and CHIP in the 50 states and the District of Columbia. Medicaid is a state-administered benefit program with guidance, requirements, and share funding from the federal government and individual state governments. Each state provides the minimum federally mandated services and coverage for federally mandated eligibility groups. However, state benefits may vary from state to state. Medicaid covers many groups of people, depending on the state's requirements, such as age, pregnancy status, disabled, blind, aged, income level and resources, U.S. citizenship, and lawful immigration status. There are also special rules for those who live in nursing homes and for children with disabilities living at home. CMS administers the Medicaid program jointly with states. CHIP stands for the Children's Health Insurance Program. It's the insurance program that provides low-cost health coverage to children in families that earn too much to qualify for Medicaid, but not enough to buy private insurance. In some states, CHIP covers pregnant women. Each state offers CHIP coverage and works closely with its state Medicaid program. Beginning in 1999, CMS required all states and the District of Columbia to submit their data via the Medicaid Statistical Information System, known as MSIS. Because Medicaid and CHIP programs vary by state, CMS requires states to convert their data into a standard MSIS format. More recently, in an effort to enhance reporting for these programs, CMS replaced MSIS reporting with reporting in the transformed Medicaid and CHIP Statistical Information System, TMSIS. CMS uses the raw MSIS and TMSIS data to develop research files. We have two research files, Medicaid Analytic Extract, or MAX, and the TMSIS Analytic Files, or TAF. The transition from MSIS to TMSIS did not happen simultaneously for all states. The majority of states transitioned to TMSIS between 2013 and 15. Consequently, CMS can offer one of two distinct research file products, depending on the year and the state. Both MAX and TAF organize data in a manner that makes them easier for researchers to use for analysis. MAX is available from 1999 to 2015 for some states, and TAF is available from 2014 for some states to 2021. In terms of the variables that are available in Medicare, we have dates such as admission, beginning, and end of service. We have demographics such as age, beneficiary ID, gender, zip code. We have diagnosis, claim diagnosis codes like ICD-9 and ICD-10, principal diagnosis codes. We have drugs, Revenue Center National Drug Code, NDCs. We have costs, beneficiary payment, claim payment, Medicare coinsurance, Medicare copay, Medicaid payment, and provider payment. For provider, we have place of service, provider or facility type, physician specialty code. For eligibility and enrollment, we have whether the beneficiary is a dual, eligibility category, monthly enrollment status, reasons for entitlement. For procedures, services, and treatment, we have healthcare common procedure coding system known as HCPCS codes. We have revenue center codes based on common procedure terminology, CPT. So we're going to review a little bit of the detail for both of the research files, MACS and TAF. Let's start with MACS. MACS contains data. MACS data contains 5 types of files, and similarly, TAF files contain these 5 types as well. We have person summary file, PS, contains annual demographic and eligibility data. MACS has hospital inpatient file, or IP, contains records for inpatient hospital stays. Institutional long-term care file, or LT, contains records for services provided in long-term care institutions. Prescription drug file, or RX, contains records for prescription drugs and other services provided by freestanding pharmacies. And other services file, OT, includes information on physician and other provider services provided while a patient is hospitalized. MACS contains both fee-for-service and managed care claims data. For fee-for-service enrollees, detailed data on service use, diagnosis, and cost of care are available. For managed care enrollees, MACS includes capitation, premium payments to managed care plans, and encounter data for the services provided by those plans. Some states slowly transitioned to TMSs. In 2014, 15 states still submitted information using MSs, and 19 were already using TMSs. That number grew to 31 in 2015. In 2016, already 98% of the states, regions, and programs were using TMSs. Therefore, there are a couple of years where MACS and TAF overlap, 2014 and 2015. Let's talk about TAF now. TAF is an enhanced version of the TMSs data tailored to the research needs of those who use Medicaid and CHIP data, including beneficiary demographics, eligibility, program enrollment, managed care, providers, service use, and payments. CMS created the TAF to support analysis, research, and data-driven decisions on key dimensions of Medicaid and CHIP, such as expenditures, enrollment patterns, program evaluation, policy assessment, healthcare quality, provider participation. There are 7 types of data files available from TMS's TAF. The annual demographic and eligibility, DE, inpatient IP, long-term care, LT, pharmacy RX, other services, OT, and then these 2 are new, annual managed care plan, APL, annual provider, APR. The DE files contain the base or core enrollment demographic file and 6 supplemental files. The base file is the primary eligibility file and contains approximately 200 variables with information on beneficiaries, demographic characteristics, and details on their enrollment in Medicare, Medicaid, or CHIP. The DE base file includes variables related to demographics, such as dates of birth and death, age, gender, and geography, like home zip, county, and state. It also includes monthly and annual enrollment information, Medicaid or CHIP enrollment days, dual eligibility, reason for change in eligibility status, scopes of benefits, how the beneficiary qualified for Medicaid or CHIP, information regarding eligibility group codes, enrollment in managed care, and indicators for enrollment in waivers. The DE supplemental file consists of the following 6 files: eligibility dates. Each record represents an enrollment spell for a Medicaid or CHIP beneficiary. The managed care enrollment MC contains records for each beneficiary who enrolled in some form of managed care. The waiver program enrollment, there are 10 waiver programs such as pharmacy, disaster-related, family planning, health insurance flexibility, and accountability. Money follows person, or MFP, contains records for beneficiaries who participated in an MFP program. They support state strategies to rebalance their long-term services and support systems from institutional to community-based care. Health Home and State Plan Options, or SPO, contains records for beneficiaries who participated in a health home, enrolled in an SPO, or had a health home chronic condition. Disability and Need contains data for beneficiaries who met one of the following criteria: met the requirements for long-term services and supports program eligibility, was eligible through the conception to birth option, participated in other government assistance programs, had any of the following: a home and community-based services chronic condition, a lock-in provider, a disabling condition, or third-party liability coverage. TAF also contains inpatient files, which include all inpatient hospital services. The LT contains long-term care institutional claims, including nursing facilities, intermediate care facility services for individuals with intellectual disabilities, mental health facility services, and independent freestanding psychiatric wings of acute care hospitals. The OT file includes services such as physician, outpatient hospital, dental, other services such as chiropractors, podiatrists, psychologists, optometrists, clinic, laboratory, X-rays, sterilizations, home health, personal support, and managed care capitation payments. The RX file contains information for covered prescription and over-the-counter drugs. The APL file contains information about each managed care plan or waiver entity authorized to operate in the state. It includes managed care name, type of managed care plan, the various locations of the managed care plan, the various service areas in which the managed care plan operates, operating authorities, and eligibility groups authorized to enroll in each plan. It includes 5 files, a base file, and 4 supplemental files. The APR file contains information about the providers that are eligible to render services. Providers may be facilities, groups, or individual practitioners. Variables include provider name, provider type, the provider group, facility-specific information, and the various Medicaid CHIP programs, waivers, or demonstrations, provider taxonomies, affiliated groups, locations, licenses, and identifiers associated with the provider. The APR is comprised of 9 files, a base file, and 8 supplemental files. The TMSIS differs from MSIS in several important ways, including the timing of submissions, monthly versus quarterly, and the amount of content states report, while improving the data's quality and timeliness. TMSIS has nearly 4 times as many data elements, including several new segments. TAF contains information on a broader set of individuals than MAX, as it includes the separate Title 21 chip or S chip, while MAX does not. Examples of data elements submitted by states through TMSIS compared to MSIS are new demographic information such as household size, additional program enrollment and benefits information such as more waiver details and more managed care enrollment details. Two-part claims, the header and the line. Headers plus all line records are available in TMSIS. MAX was limited to 26 lines. And we have two additional files, the APL file for managed care plans and the APR file for providers. Let's talk about the benefits of using Medicaid data. The Medicaid data provides a wealth of information, including quality metrics. Well, the next two slides have examples for those metrics, and it has all age brackets, so you can analyze a wide variety of individuals. Because of the TMSIS and the CMS push towards value-based care, Medicaid providers can also voluntarily report quality measures. This slide shows a sample of some of the child core measures being reported, available for research purposes, and how many states are voluntarily reporting them. In 2020, all states were reporting measures such as adolescent well care visits aged 12 to 21, well child visits in the first 15 months of life, as well as in the 3rd, 4th, 5th, and 6th years of life. These measures are examples from the adult core SEC quality measures. The vast majority of states were reporting measures such as cervical cancer screening, ages 21 to 64, diabetes screening for people with schizophrenia or bipolar disorder who are using antipsychotic medications, ages 18 to 64, adherence to antipsychotic medications for individuals with schizophrenia, age 18 and older. As an example of a published research, we have the physical and/or cognitive impairment, out-of-pocket spending, and medical entry among older adults, published in 2016. Using the Health and Retirement Study, HRS, was one of our NIA Linkage program affiliated studies. This research found that being underinsured is a significant predictor of entering into Medicaid coverage over a 16-year period. The rate of entering Medicaid was almost twice as high for those who were underinsured and with physical and/or cognitive impairment than those who were not, while the supplemental health insurance reduced the rate of entering Medicaid by 30%. Providing more comprehensive coverage through the traditional Medicare program, including a ceiling on out-of-pocket expenditures or targeted support for those with physical or cognitive impairment, could postpone becoming covered by Medicaid and yield savings in Medicaid. Let's turn to challenges to working with Medicaid data. There is longitudinal inconsistency because there are two different systems with a transition between 2014 and 15. We have 50 plus entities reporting data, and there's varying quality and completeness between the two systems. The next slides will talk more about quality and completeness. Administrative data often have errors or missing fields, especially if not required for claims payment. As an example of anomalies in the MAX files, We have here the IP files in 2011. There are tables with anomalies with different variables and states. In this example, the anomaly table is showing us that Kansas has 7%, 7.6% of missing eligibility, and Maryland has only 42% of reported MPIs. For TMSIS, we have resources available that show us different variables in different years. In this particular case, we have diagnosis codes in the IP files, and it's showing us that 2 states have unusable data because the ICD-10 codes are less than 50% reported, and those states are Tennessee and Maryland. I'd like to determine if you know how to use these resources or if you would like me to show you how to access them. We created a poll and we'll give you a moment to respond. We'll decide a course of action based on the preference of the majority. So Christina, if you can help me send the poll, that would be great.
So I think we're encountering issues with the poll feature. I think we can proceed with reviewing the items.
Okay, that sounds great. Okay, so Christina is going to send in the chat box the links for these 2 pages that I'm going to present. So this is the MAC's main page at the cms.gov page. When you go to the end, you can find a lot of information per year. In this particular case, I chose the 2011 as for the example. When you click here, it's going to download a zip file that is going to look like this. And you can see here, the one that I chose is the first one, claims anomaly tables. There's other anomalies like eligibility. You have all of this information available. When you click on the file or you're able to unzip it, you will see this file has a lot of tabs for different file types. And in this particular example is the IP. And the table has footnotes that help you understand what it's being highlighted. In this particular case for missing eligibility is footnote B. It shows that the values above 2 standard deviations from the arithmetic mean are considered anomalous. Kansas is one example of that, and is missing almost 8% of eligibility. For the percentage of MPIs missing, the footnote C tells us that the values less than 95% are below the expected level and are considered anomalous. And there are certain examples here. California is one of them, Delaware, but Maryland is only 42% MPIs are reported in that file in that year. And in terms of, so this was for MACs. For TAF or TMSIS, Christina is going to share these, the DQ Atlas, Data Quality Atlas. It's available as a map or as a table. And I think I had 2017. You can select enrollment. There's a lot of options on the left-hand side. You can find like beneficiary information, enrollment. What I picked for the example was the IP. And I selected the year 2017. You can see it as a table. The definitions are on the right-hand side. The map is pretty visual, so it's very helpful. And the definitions are also here. It shows us, like I said, these two states are, the data is unusable because the percentage of valid ICD-10 are below 50%. If you look at subsequent years, like 2018, you see that Maryland corrected the issue in 2018. Tennessee still had it in 2019, the same, but in 2020, the problem was solved and all the data is usable, and same with 2021. So these resources are pretty helpful to identify if the state that you're analyzing has any issues or not. Okay, let's go back to the presentation. Let me make sure in the chat. Yeah, okay. In terms of data completeness, race is not required. Thus, it may be incomplete. Accuracy may vary across states. Waivers, some states don't report any information, particularly in the months after the waiver is first implemented. In terms of payment amounts for private insurance, third-party payment, and Medicare coinsurance and cost sharing, these data elements are not widely or completely reported. New data has varying quality, completeness, and consistency when a variable is first introduced. As we could see in the previous slides, there may be state-specific issues in terms of data quality, and it depends on the state and on the year. But most importantly, because we're analyzing state data, is not nationally representative, and thus research findings are not generalizable to the whole US and are limited to the specific states analyzed. And there are particular states with issues like Illinois, whose data does not include final action claims. This state processes incremental claims rather than replacement claims. There's even a special RESDAC documentation to know how to deal with Illinois claims. In terms of procedure or diagnosis codes, for IP procedures, MACs from MSIS, that is pre-2014, uses ICD-9 codes, and TAF uses mainly ICD-10. There are exceptions. We already saw the case of Maryland, which did not use ICD-10 in 2016 and 17, and as such, the counts of conditions by diagnosis in those years are completely out of line with expectations. For OT medical services, the codes that are used are the CPT and HCPCS. However, states may use a specific coding. Users may identify the coding systems used by a given state by looking at the procedure coding system data element. If the codes used are not standard national codes, the data element will have a value of other. Managed care is very prevalent in Medicaid. In 2021, around 85% of beneficiaries were enrolled in managed care organizations or MCOs. Some states' MCOs do not submit encounter data in a timely manner, and thus we often see missing data. The Center for Medicaid and CHIP Services, or CMCS, at CMS has required redaction of some payment fields for managed care claims due to the proprietary and confidential nature of this information. When summing expenditures using the claim files, either header or line, It is important to keep in mind that totals do not reflect the redacted managed care expenditures. Eligibility status can change frequently. Most states have a unique ID. It's called the MSIS ID, and patients can end up with more than one. Data is voluminous and can be cumbersome to analyze. Sometimes data refreshes, and if there's a complete revamp of the data, that could render analysis spurious. So one has to be careful about that. When conducting research, given Medicaid's complexity and the variation in programs and data quality across states, researchers need to consider a number of factors when selecting states, study populations, and data elements for inclusion in their analysis. For instance, to define the population of interest, one needs to decide which is the relevant population to analyze, whether full year or partial year, fee-for-service, managed care, dual eligibles. To analyze service use expenditures, it's important to understand the variables and what information they contain. For fee-for-service, the Medicaid payment amount data element provides information on Medicaid payments for fee-for-service services, including both federal and state contributions. The Medicaid paid amount for a given service does not equal the total cost of care when an enrollee is dually covered by Medicare, when an enrollee has private insurance, or when an enrollee has any out-of-pocket liability. However, the payment does represent the total Medicaid expenditure. For capitation claims, premium payments to managed care plans for risk-based capitated coverage do not identify services provided under capitated coverage. They are included in the OT claims file instead. They include managed care plan IDs, and researchers may identify the managed care plan and type of plan. To calculate the total amount Medicaid paid for the services provided to an enrollee through a capitated managed care plan, users may sum the total capitation payments made for that beneficiary to that plan. It is important to fully understand all programs and coverage when designing the research. For example, in an analysis of hospital admission rates, the inclusion of individuals who receive very limited Medicaid benefits, such as only family planning services, could lead to biased results. What is the unit of analysis? Is it the beneficiary? Is it a particular variable, such as expenditure? Is it a specific state? Answering that question would aid in the correct study design. When linking variables, more than one MSIS ID and state code may be associated with the same beneficiary if the enrollee is in Medicaid or CHIP in more than one state. In fact, that beneficiary ID may also associate with more than one MSIS ID in the same state if the eligible has multiple non-contiguous spells of Medicaid or CHIP enrollment. As such, when joining the DE enrollment files together, one has to use a combination of MSIS and state code. If researchers are using multiple years of data and wish to identify the same person longitudinally, the researcher has to use the beneficiary ID to identify the same person across states. Also, for longitudinal studies within a state, researchers may wish to use the MSIS ID and the state code. The beneficiary ID is a linking variable across CMS files. So a Medicaid beneficiary can be linked to Medicare files if they have any Medicare claims. In the NIA CMS linked data files that we produce, that variable is called BID and is a mass beneficiary identification number. When summarizing Medicaid data, use the beneficiary ID when available to identify all the claims for a beneficiary for a particular year. If there's not a beneficiary ID for the record, then use a combination of MSIS and state code. The beneficiary ID allows researchers to look across states for a more complete view of enrollment and services. Working with states, we already reviewed a few particular states that may have data quality issues, and we have learned how to find out which states' data may be unreliable. I think this brings us to the end of the presentation. Here's how you can contact us. You can use the email on the screen. The phone number, our hours of operation are 8 to 8 Eastern Time. We're happy to hear from you.